Welcome you to today's session in our ongoing series of events, COVID-19 Beyond the Biology. And in today's panel discussion, we're going to focus on the issues of social distancing, actually something I like to refer to as physical distancing, and interpersonal violence, and the relationship between the issues that we're facing with the current pandemic and how it's affecting interpersonal violence in our communities. And this is part of our ongoing series of issues that are intersecting with the changes in our world and underlying fundamental public health issues that we deal with even outside of a pandemic. And today I'm pleased to be joined by three members of our faculty from our college's School of Social Work to discuss these issues. Dr. Melissa Dichter is an associate professor in the School of Social Work. Dr. Julia Kobulsky is an assistant professor in the School of Social Work. And Dr. Bernie Newman is an associate professor in our School of Social Work. So to begin, I want to start by asking Dr. Dichter a question. Dr. Dichter, can you explain for us how you define domestic violence and how it differs from a term I've heard you use to describe the phenomenon called intimate partner violence?
Yeah, so these terms, domestic violence or DV and intimate partner violence or IPV, are sometimes used interchangeably. But domestic violence has really been used to be a broader term, sometimes encompassing child maltreatment or elder abuse, sometimes referring to violence that occurs in households or among family members. So we use the term intimate partner violence or IPV to refer specifically to the violence or abuse that occurs against a current or former intimate partner that does not necessarily occur within a home or a family.
So it sounds like it's really a more specific form of the types of issues around violence and neglect that we may see in a home.
Yep.
Okay. And then Dr. Kobulsky, can you, to help kind of orient our discussion a little bit today, can you similarly define for us the term child maltreatment? Because as I've understood from you and others, it's a little bit broader than perhaps we used to think about this issue 20 and 30 years ago.
Yeah, sure. So broadly, and I do in my research take a broad lens in terms of child maltreatment, and sometimes that conflicts with, for instance, what we might understand as a legal definition of child maltreatment, which tend to be a bit more narrow. But child maltreatment are caregiver or parent behaviors that present harm to children. And that harm can be actual harm, it can be potential harm, and the type of harm can be physical, emotional, social, all the different types of harm. So most typically when we're talking about child maltreatment, we're talking about abuse and neglect. And specifically the most common types are physical abuse, sexual abuse, emotional abuse, and then neglect, which can be supervisory neglect or physical neglect, as well as emotional neglect. So that's usually what we're talking about.
So can you give us a concrete example of emotional neglect? Because, you know, one of the things that as somebody who's trained as a clinical psychologist, you know, when I was seeing patients, I know that patients would often come in and talk about issues related to, you know, I didn't really get along with my mom, or my dad wasn't there to be emotionally supportive to me. But I've always been challenged by trying to figure out, where does not having our own emotional supportive needs get met cross the line in terms of neglect? Are you able to shed some light on that?
Yeah, it is really tricky because there's definitely a spectrum of behaviors. And then at some point we say, like, okay, this harm now qualifies it as maltreatment. And especially when you're talking about neglect and emotional neglect, like drawing that line can be really unclear. But consider an instance for maybe you have a child who is so distraught that he or she is considering hurting him or herself. In that case, it's a parent's role to attend to that child's emotional needs, and not attending to that would clearly present a risk of harm. So that's one example. Another example is children have needs to socialize, right? And that's relevant here if we're thinking about the pandemic, and especially as they get older and maybe reach adolescence, that social life is so important. So if a parent isn't allowing that normal like social interaction to happen and maybe being overly restrictive, that could be a form of emotional neglect as well.
Yeah, I think you just touched on something that's been in the Philadelphia Inquirer for the last couple of days. I think there's a question on their homepage saying that if our family has been home for the last 2 weeks and everyone is safe and healthy, and my child's best friend is been home for 2 weeks and is safe and healthy, is it acceptable for them to get together for a play date? And I'm not asking you to answer that question because I think it really gets beyond our expertise as social scientists, but I think parents are really challenged by some of those issues now of how do we protect our kids physically, but also realize that the social isolation and the distancing is taking a toll on all of us at the same time. So another question, another term that I want us to define up front relates to the term elder care abuse. And obviously many of us know that there's been a tremendous amount of discussion about what's going on in the nursing homes and elder care facilities around the country, how we're seeing clusters of COVID-19 cases in those areas. But Dr. Newman, can you tell us a little bit about how we define elder care abuse? And does that also, like child maltreatment, include issues of neglect as well? Dr. Newman, I think you might be on mute.
Do that. I'm sorry. Yes, I'll be glad to define it. The CDC suggests that it can be considered an intentional act or a failure to act, either by a caregiver or another person who's in relationship with an elder, where there's an expectation of trust, and that act or failure to act causes either harm or risk of harm. And like other forms of domestic violence, it has a wide span. It can include physical abuse, of course. It also can include sexual abuse or abusive sexual contact. It has also forms of neglect where the elder's needs are not met in terms of caregiving or emotional needs, and then emotional or psychological abuse can also occur among elders. And then finally, there is financial abuse or exploitation, which is also very problematic when people in positions of trust are exploiting elders, and that can be considered a form of abuse as well.
So it's obviously much broader than maybe the first thing that we all think of, assuming that somebody is physically abusing an older relative who may be frail, who doesn't leave the home, maybe if not only physically abusing, but maybe threatening them in some way. If you don't give me money, I will hurt you in some way. I really like too how you started that explanation by talking about that breaking of an agreement of trust, in that, you know, I can imagine there are a lot of people right now because of their concerns about the virus or their inability to get out of their homes more generally, who have an agreement with a child or a neighbor, probably more a child, to say, an adult child who would say, okay, well, I'll come over every third day and check on you and make sure you have your medications and make sure you have food. And if the adult child doesn't show up regularly, that seems like it would be another example of elder care abuse, where somebody is left alone and isolated without the resources they need to be safe.
Yeah,
so
and that
one
can
of the
be
questions
extremely harmful.
Yeah. So one of the questions I'd like to throw out to all three of you, it again refers to things that I've seen in the Philadelphia Inquirer over the last few weeks. And I think in the first few weeks that all of us were at home, there was an article that had suggested that at least through the month of March, that reports of child abuse and intimate partner violence were actually down approximately 20 to 25% throughout the city and maybe even the region. Do the three of you have a sense that those reports are accurate, or what, based on your expertise, do you think is probably really going on right now?
I think it's very, oh, go ahead, Melissa.
So I think a decline in the official numbers is likely reflecting a decrease in reporting, less so than a decrease in incidents. I think Julia can talk about the way child maltreatment reporting occurs and how often that comes from a school setting, for example, where people are mandated to report suspected abuse or neglect. In the case of intimate partner violence, it may mean that people are really limited to doing things like, I think what's reported in the newspaper is often about police reports. And so if it's hard for you to get away from a partner, if you're stuck at home with that partner, it may be hard for you to have access to reaching out to the police or to the domestic violence hotline to find a safe and private place to be able to do that.
Yeah, I would absolutely agree with Melissa. I think it really reflects the inability of victims to reach out right now because of the stay-at-home orders. And for victims of IPV, they may not be able to get away. They don't have a reason to leave the home, and the abuser may be right in the home. Sometimes they may not even have the space to make a phone call or send an email because the abuser is so controlling. Mm-hmm. And Julia, talk about child maltreatment.
Yeah, I can comment a bit on the child maltreatment side. So I think in normal times, we have to keep in mind that there's limitations to using Child Protective Services reports to understand the prevalence and incidence of child maltreatment. And because those reports there's a lot of maltreatment that's never detected. They're also subject to the way maltreatment is defined. And they depend a lot on mandated reporter laws and also mandated reporter behaviors. So what we see now is that children are taken out of school. All these kids are out of school, and so they're living in much more isolated circumstances where they're not being observed by potential reporters of maltreatment. And so I strongly suspect that those decreases are a function of that isolation of the children, especially when we consider that many of the risk factors for maltreatment are actually going up because families are under significant stress due to the pandemic.
Yeah, it sounds very much parallel to what I'm hearing from our colleagues in medicine and in hospital settings who are saying that the number of patients who are coming in with chest pain or in GI distress, having stomach problems, is also down a similar percentage. And it's not that we suddenly think that those things aren't happening to the people in our communities and in our city. It's just that because of our inability to get out of our homes and perhaps our concern about going to a healthcare facility lest we be exposed, individuals are probably staying at home more and are exposed to the violence and the neglect, or are suffering with health problems and not getting the help that they need. So Dr. Newman, I want to turn back to you. Can you comment a little bit on how our current situation has probably increased some of the risk factors related to domestic abuse?
Yeah, thank you, Dr. Sarwer. Actually, the established risk factors from the research for domestic violence are really mirrored in the COVID-19 pandemic conditions of social distancing. So if you think about it, we've got social isolation, which is a huge risk factor for any form of domestic violence. And we're have people being isolated from others who they have relied on for support outside the home that they may not have access to. There is a lack of social support, a lack of ability to reach out to extended family or friends or mandated reporters. In addition, we're all feeling a little more stressed, perhaps depressed and anxious because of all the conditions. And that is a risk factor for DV. When parenting stress increases, parents have lots of more demands and a bigger burden put on them with little or no respite care now. That certainly is a risk factor that the research suggests is already a risk factor for abuse and neglect. And here we're in this situation, all of us. But the pandemic really adds to the risk factors. You've got, as Julia said, the schools are closed. the child care centers are not able to operate. So that release, that time away from our children is not there. We're living in close living. There's less routine, and there's bigger work burdens. Those on the front lines, very low income workers that are delivering essential services but getting very low pay are very stressed, or people are working from home with their children there, or people have lost their jobs. And there's too many in our society that really lack any form of safety net. And so this loss of income, loss of jobs is really highlighting the disparities in our society, and creating even bigger health disparities than we already have and we know already exist because of race and income.
Mm-hmm. And Dr. Dichter, are there other challenges that we face right now to address domestic violence given our current circumstances? And we'll talk about adults, and then I want to pivot a little bit to children.
Right. So with the stay-at-home orders and the physical distancing, not only are we having increased risk, but we may have increased challenges to accessing resources and services and supports. People might not know where to go to get help and how to access those. We talked a little bit about not having access to privacy to even make a phone call in private. So there are challenges to that. Often in cases of intimate partner violence, people develop what we call safety plans. Those safety plans can be really helpful for what to do when an incident escalates to keep yourself safe. Sometimes those safety plans involve going to a neighbor's house or going to a friend's house. And that may be more challenging now. People may not feel like their friends or neighbors or family members would be receptive to them coming in, or that there isn't access to do that. So the largest additional challenges now are ability to reach out and access those sources of support.
And to that point, is there reliable data on how an initial report of intimate partner violence is captured? Meaning, is it more likely that the victim says to a healthcare provider or says to a neighbor, "I'm in a dangerous situation," or is it more common that a healthcare provider or a neighbor senses that something's amiss, or sees bruising, or sees a black eye and initiates the conversation?
Those are good questions. We don't have great data because there isn't a single reporting system for intimate partner violence. Our prevalence data come largely from surveys and interviews we do with individuals, and we ask about experiences. It's often hard for people to disclose those experiences when they're right in the thick of it.
Right.
But healthcare settings are critical for providing information, and increasingly healthcare settings are conducting routine screening of intimate partner violence. I think the point about bruises is really important as well. Both Bernie and Julia mentioned the non-physical forms of violence that happen.
Yeah.
And these are often actually the most harmful and the most common forms of intimate partner violence, those that don't leave the physical bruises. Mm-hmm. So I think it is really important that people are checking in and asking people, how are you doing? And that people who are experiencing intimate partner violence also recognize that they can reach out and ask for help, even if they don't have those physical bruises and injuries, that there are other forms of kind of harm.
And related to this, and Dr. Newman, you may want to chime in here as well. I've seen more and more discussion of the black dot, or the use of the black dot, where if you are in a physically harmful situation and you go to a healthcare setting, that you put a black dot, I believe it's either on the palm of your hand or on your wrist, and that's a cue to the healthcare provider that there's some form of intimate partner violence, some form of abuse occurring in the home. So if you are there with the perpetrator, you're able to communicate that, and it prompts the screening. Are you both supportive of that approach, and does it seem to be helpful, or is it still too new for us to really know?
Oh, I think you're on mute, Bernie.
Oops. Go ahead, Melissa.
So I think what we see here is a lot of creativity that people engage in around ways of kind of privately and confidentially communicating need that comes up. So sometimes it is those kind of, I put a black dot to indicate that. I mean, that's only really effective if the people to whom you're trying to communicate understand that that's the case. Other times people have gotten creative, for example, when calling the police, pretending that it's a pizza delivery, right? Or, you know, finding ways of confidentially and secretly getting that information across. I think the message to people who are available to help in those situations is that if someone is trying to communicate something with you, make sure that you're finding ways to communicate in private. We often have to remind healthcare providers and others that, you know, if you're asking about domestic violence, make sure that you're not doing it with anyone over the age of 2 in the room, that there may be partners and others who are there. So if you feel like someone's trying to communicate something with you, find creative ways to get that information communicated confidentially and privately.
And Dr. Newman, do you have anything to add?
I'm so happy that Melissa said that you have to know that the person is, what the person is communicated. And the reason I didn't speak up right away, I'm not familiar with the black dot. So if somebody had shown me that, and I'm very impressed that you are, David, but if somebody had shown me that, I wouldn't know how to interpret it. And I think that it's really important that I better learn about this, and I am going to look into this and learn more. That's why I'm really glad we're doing this this webinar, so we can share some of this information. But I do think that creativity and that ability to find ways to get around the abuser may be really critical, and we all have to kind of keep track of all the different creative ways that people are doing it, and I certainly support that.
So it really does sound like that not only, and I like your points about the need for people to be creative, but it also sounds like that we as a mental health community need to do a better job of training and teaching our medical colleagues in terms of how to look for certain things, how to ask appropriate screening questions, how to do that in an appropriate way and not when there's young children in the room. And, you know, I think for those of us who have been in those situations or been in situations like that, where kind of our clinical radar goes off and we know something's going on and we just can't figure out exactly what it is, we're often challenged to be creative ourselves and figure out a way to have somebody take the child out of the room for a few moments so we can ask the relevant questions. So related to that, Dr. Kobulsky, can you talk a little bit about some of the challenges that are specific to cases of child maltreatment?
Sure. Yeah, there's several kind of in terms of getting help informally and more formal help. So in terms of kind of informal help, like I'll say one of the big challenges right now is childcare and the stress that that puts on parents. So with the closing of schools and many daycares, this caregiving support that is gone. And so for parents who are working and are essential employees in particular, they need to find childcare for their children. And given the shortages and the scarcity of those resources, it's more and more of a risk that there will be kind of subpar care, which leads to risk factors for maltreatment. So there is that. But then even just more informal parent supports that were once there, like family members who would provide assistance and parental support, like getting that kind of help now is also harder. While at the same time, it's harder for parents to take care of themselves.
Sure.
right? Because they're stressed out themselves. So it's really important right now that parents are taking care of themselves and being more flexible with themselves and also their children. So there's kind of that level of challenge. But in addition to that, in terms of accessing kind of professional help, there's challenges to identifying those who need the help. As we already talked about, you know, they may not be observed by others who can point them into the direction of needed services or report a child who is in harm's way. So that is a big challenge right now. But then even if they are identified, it's harder to get the help that you need right now because of the physical distancing measures that we're under. And so, but parents should know that if they do need help, there is still available. Like you can still get, you know, mental health support. You can still get substance use support. And I'll add, it is like those are kind of our known risk, some of our known risk factors for child maltreatment. So if there's parental substance use, if there are mental health problems, those are some of the risk factors. But I think that the stresses that we're seeing now put previously stable families at risk as well. So it's not really like, I think that this is a pretty wide potential problem. I think another challenge that I'll add to, and this echoes what Dr. Newman was saying, was just the financial stresses that parents are experiencing right now. So when we have so many children, you know, so many parents who are unemployed, that is the financial stress is very real and can, I mean, the stress could cause maltreating behaviors, but then it could also make it harder for parents to meet children's physical needs. So kind of thinking about physical neglect and that, even though it's not the fault of the parent, it is still the risk of that need that isn't being met.
Yeah, I think two things really struck me in your response there. One, I think many of us have been humbled, if not sobered, by the news stories that have shown the length of food lines, of you know, food pantries that have popped up in major urban areas. You know, I'm originally from Chicago and a huge Chicago Cubs fan, and there was a pop-up food pantry outside of Wrigley Field yesterday. We've seen reports in cities like Los Angeles and Las Vegas where the lines are hours long. And so I do think your point about not being able to access resources, including things like food, is definitely something that a large percentage of our population is dealing with. But then you also dropped a really, I think, elegant clinical pearl in there, which is, you know, I think for all of us right now as parents or as the adults in the home, if we don't take good care of ourselves, we are really challenged to take good care of other people in our care. And that means, you know, we have to be doing things like getting enough sleep, getting time to, you know, clear our thoughts and not think about our work and not think about the stress and anxiety and disconnect from the media coverage and social media and so forth. Because if we don't take care of ourselves physically and psychologically first and foremost, our ability to take care of others is just profoundly limited. And unfortunately, I think that can oftentimes be the entry point to, that can actually be the entry point to, you know, some of these issues of maltreatment and neglect and abuse that we're talking about today. So I know that you know, we are all looking for things that we can hang our hat on and be optimistic. And we know that the number of cases in the city and the region are beginning to drop. And we're, you know, I think all very optimistic that will continue to happen. And that we will start to, although it'll be slow, we're going to start to return to some element of normal in the weeks and months ahead. And I think for a lot of us, it's important then to realize that there's going to be some opportunities there. So I'm going to start with you, Dr. Newman. What do you see as some of the opportunities for not only kind of the management of these, of intimate partner violence and domestic violence, but also maybe the research in this area as we return to some element of the new normal?
I want to go back to the under reporting that's going on. And I think that we need to be prepared for a surge in reporting when the physical distancing does end, and that we can do that now. We can think about how we're going to be able to be available and respond in an effective way to the number of reports that are probably going to emerge in the number of cases that will come out that have been going on for a while. So we can plan that. I think we also are learning a lot of lessons about our ability to provide remotely services, counseling, support groups, healthcare, and even education in terms of when we have to, we are being creative and inventive, and there are lots of ways that we should be doing that now, even with the physical distancing. I think it's really important to know that it's a time when, even though the access to services may be different, it's really important to point out that all of that domestic violence services are considered services that are essential, and they're all available, maybe in slightly different ways, but they in fact continue to be open. Shelters are open, hotlines are open, people can reach out now and in the future, I think it's and that the programs are being very creative. We haven't stopped providing services for either child protection or domestic violence, and they need to really. I really want to give my my admiration to folks that are continuing to do this in this way. So people should be reaching out to services, and we should be planning to be able to maybe create a reward system or work, rethink how we look at work and how we pay our childcare workers, our domestic violence advocates, our child protective service workers. And this should be a wake-up call in a lot of ways to our society around these essential workers that have very low income, and now we really need them. We need people to be in the grocery store and to be picking up the garbage, and we don't pay them and value their services. And as a society, I would like to see us move in a direction of documenting this in our research and really making a case for a guaranteed family income, for a minimum income that is not in the poverty level as we do now with the TANF program, and to see that people are so on edge in our very rich society that when a pandemic like this happens, too many families are going over the edge, and this really shouldn't be happening in our society. So in my research, I hope to be documenting some of this and making a case and being an advocate for larger structural changes to the society.
And I think you have many other people who are in complete agreement with you that maybe one of the silver linings that can come out of this down the road is that we really do use this as an opportunity to relook at how we treat one another, how things are designed in our policies and our social support networks and social services, because the current system, I mean, those of us on the inside have known for a long time it hasn't been working and that it needed change. And I share a little bit of optimism that we're starting to see that pivot to telehealth and the use of technology like this to provide mental health services. But as you articulated, there are many, many more issues that we need to address as well. Dr. Dichter, what are your thoughts on this issue?
Yep. So
it's a hard act to follow.
Well, I'm fortunate to do a lot of the work that I do in the community and in research alongside with Dr. Newman. And so one of the things that we've been doing the last few weeks is work with a lot of survivors of intimate partner violence who have come together as a survivors network through a local domestic violence program. Mm-hmm. And so we've switched our research interviews to online interviews, and we've also had some group meetings with some of the survivors. We're working on writing an article together about how survivors can support each other particularly during this time. So some of the things that have come up is about the utilization of technology and how that really grants a lot more access to folks. But at the same time, it's critical then that people have access to the technology. One of the survivors that we've been working with noted that she said, you know, Wi-Fi really is not a luxury. It's really an essential service. She's doing a job right now that she can do from home, but requires her to have Wi-Fi. So she's quarantined at her boyfriend's house. And fortunately, this is not a relationship where there's currently abuse, but she notes that if there is a relationship where there is abuse and you're reliant on someone else for something like Wi-Fi access to maintain your employment, that's really an issue. So as Bernie mentioned, I think there's a lot of opportunities here to address disparities and wake-up calls. As you've mentioned, there's a lot of opportunity here to expand some of that telehealth work and counseling work. The domestic violence programs have become really creative in ways of continuing to deliver their services, and IPV survivors who are no longer in a currently active abuse situation really have a lot to offer in terms of supporting each other and other survivors as well.
Yeah, and just to stay with this kind of more general issue of social determinants, I had a conversation with one of the endocrinologists up at the hospital at Temple late last week, who told me that in his diabetes practice, his no-show rate for his outpatient appointments traditionally, when they're in person, is 40%. As he has pivoted to telehealth, his no-show rate has dropped to essentially zero. And so he actually had to talk to the schedulers to say, you need to not double book patients because everybody is showing up online. And I think it illustrates a really important point, which is it's not that patients in our communities don't want care and don't want help. It's that the resources available to them to access that care simply are not there. That they, you know, whether it's a childcare issue, whether it's change for transportation, whether it's I can't take the afternoon off because I've exhausted my sick time. It's not that our patients don't want our help. It's just they can't access us. And so maybe one of those wake-up calls is that we as healthcare providers need to do a better job of figuring out how to go out rather than to insist that people come to us in that old school model of healthcare. And so I share some optimism that that may be something that we see going forward as well. So as we're beginning to wind down here, and I'm going to turn to Dr. Kobulsky for her comments in a minute, for those of you who are participating today, if you have any questions, feel free to drop them in the chat box, and I'll begin to circulate those questions to our panelists in a few moments. So Dr. Kobulsky, what do you have to add in terms of thinking about the issues around childhood maltreatment, about the opportunities that lie ahead for all of us?
Yeah, well, I think it's great to remember that it's not all risk, right? There is like definitely strengths in this situation. And when we think about families, for example, many families are now spending a lot of time together. And I can speak for myself, having been cooped up with a 2-year-old and a 6-year-old for the past 7 weeks. But there is a lot of silver linings to that too, in terms of the ability to build some attachment and family cohesion. And so it's not all doom and gloom by any means. So there's some strength to that. And I have to think also that the widespread experience that we're all going through, I think, is building up a lot of compassion and empathy in people that maybe we didn't see before. So it's interesting, in the beginning of this webinar, David, you mentioned it's a choice. Like, how do you weigh these options of keeping your child isolated, which really isn't meeting their needs for social outlet, or putting them at physical risk? Well, for families at risk of maltreatment, they're making these kinds of choices every day. They're often dealing with frankly, two suboptimal options, and they're forced into these positions of like, what do I do? Which is going to be the less harmful for my child? And so I hope that this builds our empathy of the difficult experiences that many families are facing, and that we can translate that as, I can't top Bernie's, how she articulated this, but just into better supports for families so they're not so on the edge. Another piece of this that's a bit more positive is in terms of protective factors, also recognizing the importance of resources for children. And those are things like that our schools provide, certainly like mental health services and behavioral health services, things like that, but also just recreational opportunities. Those types of things are so important and beneficial for our kids. So just a few extra comments there.
Great. So we have a question that's come in from somebody who's listening to the session. Dr. Dichter, can you comment a little bit about issues around racial and ethnic disparities associated with domestic violence?
Yes, so we see over and over again in research that being a particular race or ethnic category does not itself incur additional risk for violence. Violence and abuse happens across the board to all sectors of our society. What we know, though, is that discrimination and disparities that happen in society are also reflected in access to services and supports that can impact experiences of violence. So we sometimes see some racial or ethnic differences that are really conflated more with things like social class or where people are living, or access to services, and racism and discrimination. Things that we might see in a lot of the kind of publicly reported numbers in terms of police calls or child maltreatment hotline calls and things like that is, for example, if you're living in a crowded setting, if you're living in a high-rise apartment building where there's a lot of other people around, for instance, neighbors may be more likely to hear violence and abuse that's versus if you're living in a large home in the suburbs where you don't have neighbors who can hear you. People may be more reluctant to call the police or report someone when somebody is known as kind of a, important figure in society, for example. And so we see some of those kinds of disparities in reporting. We see that people who have additional resources might go to a hotel or to friends or family instead of going to a publicly accessible shelter, for example. But the bottom line is, I don't think that there's any research that indicates a particular race or ethnic group is more prone to or at risk of violence per se. But we do see disparities and discrimination in terms of access to care and services.
So as we wind things down and perhaps wait for another question that's going to come in from somebody listening, I want to give each of you an opportunity to share with our attendees anything you think would be important for them to know, or any topics that maybe we didn't touch on that you think would be valuable for people to be thinking about, not only given where we sit today in late April, but where we likely or may be come the summer and the fall and over the next period of time, not only dealing with the epidemic, but just dealing with these larger problems of maltreatment more generally.
I'll start. Melissa referred to an article that we're writing with some IPV survivors, and one of the gems that I feel like we've gotten from them is the need for outreach and for connection and for information dissemination, and the idea that everyone can be an advocate, everyone who believes that domestic violence should not exist, that doesn't think that anyone should be hurt in a relationship, in a family, can speak out about it and create more of a norm where that is just not okay, and it's not something for the victim to be ashamed about, but it's something that we all care about and that we all want to help with. So I think making connection with people, creating a sense of norms that do not tolerate any kind of domestic violence is really important, and that we can do that in little ways. We can do it with our neighbors, we can do it in the community, we can do it in the grocery store, where we might say to someone, it looks like you might be having a rough time. What's there are some resources that are available, or just showing that you care about someone is really important. I think that being proactive, both at the community level and the organizational level, but at the individual level as well, can be very powerful if we do it collectively.
Mm-hmm. Dr. Newman, while you're there, a question has come in specifically to you. You mentioned that social service and care providers should be prepared for a surge in reports in the months ahead as we kind of return to some element of normal, and I completely agree with that. Do you have thoughts on the ways that clinicians and care providers can be better prepared to handle that surge?
Yeah, I mean, I certainly would like to see some planning and some thoughtful planning going into that while we have a little time right now. And I certainly don't have the answer, but I think that knowing that this is coming and not preparing for it would be really a real big mistake. So that we can create additional funding, we can create additional staffing during this time. We really need to look at people that we furloughed, or new CPS workers, and how we should be distributing them in different ways and putting more people perhaps in an investigation role. But I certainly don't have the answer, but I do think that this is something that, and I imagine that our child protective workers administration organizations are very thoughtful about this and are trying to prepare. And I hope that they will take some time and create some organizational structure to be able to respond to this surge.
Mm-hmm. Dr. Dichter, last thoughts or little pearls for our audience members as we wrap things up.
Yes, I agree that people are saying, although we have to be physically distant, please don't be socially distant. Reaching out to others, reaching out both for your own well-being and for the well-being of others, to be informed about what the resources are so that you can share those with other people while we're all staying home and away from public spaces, and reaching out to support those services that are being offered. The services are generally run through nonprofit organizations, many of whom are having to cancel fundraising events and activities right now. Mm-hmm. And in order to continue to provide the services and address a potential surge in need for people who can donate money, who can donate resources, who can donate time to support, that can be incredibly valuable as well.
Great. And Dr. Kobulsky?
Yeah, I guess I'd like to say to parents who might be in the audience that if you're feeling, more stressed out than normal, then you're definitely not alone, and to be kind to yourself, take care of yourself as well as you can, get enough rest, take a break, do something that makes you feel happy, whether it's telling a joke, listening to music, all those kinds of things as much as you can. And so it's easy to get kind of down on yourself during difficult times like this, but I think understanding that you're not alone is helpful. And also, we haven't talked yet about the fact that this is, yes, stressful on parents, but also keeping in mind that this is quite stressful on children as well. Mm-hmm. So children are being thrown out of their routines. They may be grieving losses of completing a school year or graduation, or some kind of fun activity that they were planning, like sports or something like that they can no longer take part in. And so this is distressing for children as well. And I think that there's a need to just show similar flexibility to kids who might be behaving maybe in a little bit more challenging ways, mm-hmm. Or just thrown off of their routines. So as a parent, keeping in mind that where that might be coming from, I think can be helpful in terms of coping.
I think those were really great points for all of us to keep in mind as we're continue to be challenged by the situation we're in and maybe in for a few more weeks or a few more months to come. So for those of you who have joined us, we've just put up a slide that provides you with some information about the series that we're running here, Beyond the Biology, and really highlighting the work that we're doing across the college to really deal with this pandemic, not only shoulder to shoulder in some cases with our medical colleagues, but also thinking about some of these other issues like we're talking about today around intimate partner violence. For those of you who have any need for resources, we've provided you with this slide, which gives you a number of different telephone numbers that you can contact if you have concerns around issues of domestic violence or childhood maltreatment. I would also then just encourage any of you, if you have follow-up questions for any of us or questions about this webinar series in any ways, please do visit the College of Public Health's website. And then in conclusion, I just want to thank our panelists, Dr. Bernie Newman, Dr. Julia Kobulsky, and Dr. Melissa Dichter for really doing an exceptional job today talking about an issue that we often don't spend a lot of time talking about, but clearly is of tremendous importance right now, and as they have said, is likely going to be one of the really profound downstream effects that we're going to see in our society as we return to a sense of normal in the months ahead. So I want to thank all of you for being an exceptional panel today, and I wish all of you safety and good health in the weeks ahead. Take care, everyone.
Thank you.
Thanks, Dr. Sarwer.
Thank you.